Hello, everyone, and welcome to tonight's presentation on common oral lesions by Dr. Cohen-Brown. I'm Dr. Sam Joachim, Chief Dental Officer for Zufall Health Center, and I welcome you to Zufall Delta Dental's Clinical Excellence CE series. Before we get started, we'll just go through a couple quick housekeeping items. Everyone will be entered into this session on mute. If you do become unmuted for any reason, please make sure you mute yourself so we could hear the speaker. We encourage you to enter all your questions into the Q&A at the bottom of your screen. We will have about 5 minutes or so at the end of the session for questions. And please complete your evaluation if you are interested in receiving CE credit. We have a new process for completing the evaluations, and you'd have to go to our website after today's presentation. You will visit the zufallhealth.org/CDE site. And the first thing you will see is upcoming courses where you could register for our courses that are coming up. We will update this shortly with a number of new courses, as well as some live in-person courses for those who are close to us in New Jersey. And then the second part of the website, right below that, you will find for today's session, you'll find Dr. Brown's course with a survey link right there that you could click on to complete the survey. This will be available once again right after today's session, and it will be open for 1 week. So please make sure you complete it within that time frame, and the certificates will be sent within a couple of weeks after that. So give it a few weeks before you get your CE certificate. I'm going to turn it over now to our foundation director, Shade Cronin, for a couple of announcements and to introduce our guest speaker.
Thank you, Dr. Joachim, and good evening, everyone. I'm Shade Cronin. I'm the Foundation Director at the Zufall Health Foundation, and I welcome you all to our continuing ed session tonight. I just want to share a little bit of background with you about Zufall Health. Some of you may be new to Zufall, so we just wanted to tell you a little bit about who we are. Zufall Health is a federally qualified health center. We are located in Northwest and Central New Jersey. We have been serving patients for over 32 years. We were founded in 1990 by Dr. Bob Zufall and his wife, Catherine. You'll see a picture of them there, actually in front of our dental building in Dover. And in 2021, Zufall grew to 8 clinical sites across 7 New Jersey counties. We cared for over 41,000 low-income underserved patients. And we actually will update this slide for our next presentation. We've just added a new clinical site. We'll be opening a new school-based health center in Franklin Township in Somerset County, New Jersey. We want to give a big thank you tonight to our sponsor, Delta Dental. They have been a longtime partner of Zufall's and are the generous sponsor for our CDE course series this year. Delta has partnered with Zufall on funding our Delta Dental mobile unit, our Smiles for Our Heroes event in the fall of every year, at which we provide dental services to low-income veterans. They've also been supporters of our new clinical office in West Orange, as well as our Rural Oral Health Conference that we hold each year in November. Again, we have a number of oral health initiatives that we want to make sure that you know about. Dr. Joachim lets you know about how to access the CDE site on Zufall's website. We encourage you to take a look there at some of the additional CDE courses. We've had a wonderful series so far, and we've got a few more upcoming, another one in June and then in September. We also have our Rural Oral Health Conference that's coming up in November. This will be our 4th annual virtual conference, and we'll have more details of that coming out soon, but we encourage you to join us for that free conference as well. We've had a wonderful lineup of speakers over the last few years, and some really exciting plans in the works for that. We are also in the process of starting a new dental residency training program that will be based at our Hackettstown site. We'll be training 3 residents in the community health setting, and again, more details on plans for that are upcoming. We have a few opportunities for how you can get involved at Zufall. We are always looking for volunteers. So at a couple of the events that I just mentioned, our Smiles for Our Heroes event, when we are able to do that in person, which we are hopeful for this upcoming fall, we're always looking for volunteer providers to join us and provide services to our veterans. We're also looking for faculty for the new Teaching Health Center Dental Residency Program. So you can reach out to Dr. Joachim for information on either of those. And we always welcome you to be a monetary supporter of Zufall. So if you can visit our zufallhealthfoundation.org/donate site, if you're interested in providing support for the programs that Zufall provides to our underserved patients, we always are grateful for that support. So onto the most important reason why you're all here tonight. We have a wonderful presentation coming from Dr. Gwen Cohen-Brown. Dr. Cohen-Brown is a full professor in the Dental Hygiene Department at New York City College of Technology at the City University of New York. She received her Bachelor of Arts degree from Mount Holyoke College and a dental degree from New York University College of Dentistry in 1988. Dr. Brown is a licensed dentist in New York State and a fellow in the Academy of Oral and Maxillofacial Pathology. She was the dental expert for WebMD for 10 years and is currently faculty at the AIDS Institute. Dr. Brown is also a member of the Dental Standards of Care Committee, charged with writing current HIV clinical guidelines program with the NYSDOH AIDS Institute with Johns Hopkins. Dr. Brown authored the current monograph on oral lesions in HIV seropositive patients for the AIDS Institute, and she's lectured extensively on the topic of HIV/AIDS, common oral lesions, infection control, and oral cancer since 1992. Dr. Brown is the co-author and editor of a book published in 2020 titled The Oral Systemic Connection, a collaborative interdisciplinary clinical companion for the healthcare provider. I hope some of you maybe have heard Dr. Brown speak before, and we are glad that you are here tonight. Dr. Cohen-Brown, I will turn it over to you. Thank you so much.
Thank you so much. I really appreciate that. Let me share my screen and get back to where we were. Thank you for what a wonderful invitation and wonderful opening. I really appreciate that. So we're going to talk about some common oral lesions, and these are things that typically actually will show up in your office, do show up in your office. And one of the issues that I always had when I started learning pathology was that we were always basically looking at photos in a book, usually an old textbook, and it always had the worst case scenario of what it looked like right before the person was going to die. And it was just the most terrible looking thing in the world. And part of the reason that we wrote the book a few years ago was that Dr. Eggwes and I realized that the nursing profession wasn't really doing anything in oral lesions, and that all of the textbooks that we had were, we had fuzzy photos, we had blurry photos, and we realized that we needed to really update them. So first of all, I'd like to say that every single photo that I'm using tonight is coming from the New York City College of Technology. It is coming from the clinic there, and I'm going to just start off with Geographic Tongue, which I know most people know about, but I just want to review a very brief little bit about it. So when patients have Geographic Tongue, what happens typically is that the filiform papilla, which are one of the 4 types of papilla that are on the tongue, there's filiform, fungiform, circumvallate, and foliate. And the foliate are also known as your lingual tonsils, and the fungiform and the circumvallate are basically used for taste. The filiform papilla, basically, if you look at them under a microscope, look like little kids' party hats all stacked up, or basically like a hair follicle. And what happens is they spontaneously, for reasons that we actually do not know, will suddenly come off. Now, we've known about Geographic Tongue, and we've written about Geographic Tongue. There's pathology literature for the last at least 150 years or more on Geographic Tongue, but we still actually don't know why it happens. We do know what happens, and I'm going to tell you some of the other names that it has been called. Some of you may know that depending upon when you went to school. It was originally called wandering rash of the tongue, which then turned into I learned it as migratory glossitis, benign migratory glossitis. That's when I went to school, that's what it's called. And sometime in around the late 90s, it started changing to being called geographic tongue. And it's really called that because it moves. One thing we don't call it anymore, and I will just throw this out there because I don't think any of us are old enough to call it this, but it has been called scrotal tongue in the past. But you can understand why we're not going to call it that anymore. So with geographic tongue, typically what we often see is this white circinate or snake-like halo around this area that is deep papillated. It is most likely on the dorsal surface on the tongue, most commonly on the anterior 1/3, although you can see in this patient and actually in the next patient where it is on the, it is going distal, further back a little more than we typically see. And it's often very commonly seen in association with fissure tongue, which I'll talk about in a moment. And it's also seen around the lateral borders, usually the anterior 1/3. So this was a really interesting patient. This particular patient had both hairy tongue, which I'll talk about in a bit, and geographic tongue. So, and dentures. And his main complaint was that he felt like he had little pieces of very, very hard material, very keratotic material, almost like stabbing him underneath his dentures. And what we found actually was that he had this very aggressive geographic tongue, which would flare, which is very common with geographic tongue, and that the filiform papilla would spontaneously come off, which is what it does, and it would actually wind up going underneath his denture base. So we realized we actually had to treat this patient. I don't always treat patients with geographic tongue, but when I do, I actually will do a magic mouthwash, and I like to think that my magic mouthwash has some magic in it. The magic mouthwash I usually have, and I usually have to use a compounding pharmacist to do this, is I will use a combination of a 1-to-1-to-1 ratio of a little bit of tetracycline suspension, nystatin suspension, which is, so it's bacteriostatic and antifungal. I'll use a tiny bit of viscous lidocaine if the patients are uncomfortable. And then I'm also going to use a little bit of a steroid. So either betamethasone elixir or dexamethasone elixir. And if you put them in a 1-to-1 ratio, what I will have the patient do is take about a teaspoon of the liquid, put that onto the gauze pad, and then hold it on their tongue for about 5 minutes. Now, some patients, because I am giving them the steroid, I want them not to develop a yeast infection, which is why we put the nystatin suspension in there. It's usually not due to a yeast infection. None of this, what you're seeing, is due to a yeast infection. Although in the early part of the AIDS epidemic, I had a lot of people coming in to see me who had oral lesions, and that they were thinking that they had HIV. Now, if you look at the patient population who has geographic tongue, we do see it in infants and little kids, although it's much less common. We tend to start seeing it as people get a little bit older. It's not that it's changing or moving or developing, it's just it's coming out more. We don't, again, know why it's happening, but we do know that it does happen. And it is associated with a few diseases. So one of the diseases it's most likely to be seen in is patients who have psoriasis. So 40% of patients with psoriasis will also have geographic tongue, but it doesn't mean that if you have psoriasis, you'll necessarily develop geographic tongue. It just depends on you and your own situation. About 4% of the population in general has geographic tongue, but when you combine that with fissure tongue, it can rise up to almost 40% of the population. Okay, so I always tell the patient that if they need to go home and take a look at their own family, that if they have kids, their kids might have it. If they have siblings, their siblings might have it. And here's another thing you can blame for your parents. There is something called ectopic geographic tongue, which is possibly the worst name in the world. But this is a red and white lesion that looks almost exactly like geographic tongue. And on this one, you can see it's on the ventral surface of the patient's tongue. And if this was not in a patient who did not already have geographic tongue, which you can see that there's clinical evidence of geographic tongue on the lateral border of the tongue. If this patient did not have any known reason or there was no other geographic tongue in the patient's mouth, what we would generally do is have the patient come back in 2 weeks, see what it looks like. I like to take photos of these especially with patients with geographic tongue, since I know that it does change over time. And what I will generally do is I'll look at it, have the patient come back in 2 weeks. In New York State, and I know this is probably similar in New Jersey, you only have a limited number of time where you can not treat a patient, so that in New York State, it's about 6 weeks, so that I can look at this after 2 weeks and I can look at it after 4 weeks, after 6 weeks. If I'm still looking at it and I don't know what it is, I have two choices. I can either do a biopsy or I can send it to another practitioner who is better versed in understanding how to treat geographic tongue or ectopic geographic tongue. If it is really a patient who you don't have any geographic tongue on, assume it's a red and white lesion or an erythroplakic leukoplakic lesion, and it should be biopsied to rule out any dysplasia. This is a patient with fissure tongue, and it is very fissure tongue. He was one of my patients. He swore to me, although I don't think it's true, that his wife would come into his bedroom at night and cut his tongue with a steak knife. I tried to explain to him that that actually wasn't what was happening, but that this is also a genetic condition, as is geographic tongue, and it's seen about 3 to 40% of the population. And if you look at this, and we're spreading open the tongue a little bit so that you can see into the fissures. The fissures do have epithelium. It's not as if they don't, but sometimes you will see that the patients are complaining that the fissures are uncomfortable or the fissures sometimes hurt. And you can see over here that the patient also has some geographic tongue. If you look at the lateral borders where there's a red area with a white halo around it. And one of the things that happens is all of the detritus that comes into the oral cavity, including the microbiota, the oral candidiasis, anything that normally lives in the oral cavity, will wind up going into these little fissures. And when the tongue is closed back up, what's going to happen is that unfortunately all of the microbiota and the biofilm basically starts to ferment. And so these patients will come in with slight stinging of the tissue, and they'll also come in saying that they're slightly uncomfortable. And part of it is they're also going to say they have halitosis because they are trying to make themselves they don't know quite how to clean their tongue. One of the things I'm going to tell you not to do with patients with geographic tongue or fissure tongue is do not give them a tongue scraper, because they will very, very enthusiastically scrape all their filiform papilla off of there, and it will go into all of the little fissures on the patient's tongue, making it more difficult. So what we tend to do to clean the tongue is we'll have the patients use a gauze pad. Some patients will use a toothbrush, but some patients will gag with a toothbrush. I find a gauze pad really works well. You can use a little bit of baking soda, a little bit of water, and you just want to gently clean from the distal aspect or the dorsal surface of the tongue going forward, getting into all of these little crevices, and it will make the patient much more comfortable, and it will smell much better. They're going to be much, much happier. Okay, hairy tongue. When you're seeing hairy tongue, especially this time of the year, we're seeing red hairy tongue, green hairy tongue, blue hairy tongue. It really depends on whatever the patient's been sucking on, whatever halls or whatever else they have been doing. When you're seeing it and it's brown, it typically looks like this, and what you're seeing is a little bit of this hairiness going down the midline of the tongue, as well as on the dorsal surface of the tongue. And what it is an overgrowth of the filiform papilla. It actually isn't painful. The patients sometimes are aware of it because, again, as the filiform papilla grow, they do tend to keep a little more of the microbiota that lives in the mouth normally inside the little filiform hair-like structures, so that the patients sometimes complain that it doesn't taste good or doesn't feel good. And one of the things that happens is they will overly try to brush their tongue, or sometimes they'll use peroxide on it. And one of the things that happens if you use peroxide on it is that they will actually provide an aerobic environment for the organisms that live there, which will actually make it worse. It tends to be brown when patients are drinking a lot of drinking a lot of tea and coffee and smoking a lot of tobacco. I haven't really seen it so much discolored with vaping, although I do believe it probably can happen as well. And what we really want to do with these patients is explain to them that they should just very gently brush their tongue. They can use a tongue scraper, but it has to be incredibly gentle, because the more force that you put on it, the more likely it is that the patients are actually going to have an increased growth in the filiform papilla. It's kind of like going to the gym, and if you're lifting a lot of weights, you're going to see that your hand has a lot of calluses on it. I'm going to move on to the next picture. This patient did not know that he had hairy tongue at all, but you can see that he really has quite the hairy tongue, and he was a heavy smoker. He wanted to know whether or not we could shave his tongue or take a scissors to his tongue. Neither of those things are actually a good idea. They'd actually be quite painful, because in the filiform papilla, especially at the base of the filiform papilla, there is some actual tongue, so that if you start getting really low, it's going to start pain. It can be really painful. You can get a lot of bleeding, and we actually don't want to shave the patient's tongue. He was actually horrified that this was happening in his mouth, and we did get him to have it go away slowly. It took about 2 or 3 weeks, and it is a normal process. About 20 to 30% of the population at some point during the course of their life will have hairy tongue, and it is associated with things like xerostomia, with smoking, and also especially in the winter time when we are all living in really dehydrated areas, that the patients are breathing with their mouth, so they are actually dehydrating, and it will cause some of the filiform papilla to grow a little more. The other thing you don't want to give these patients is something that has a lot of alcohol based in it, because the alcohol-based mouthwashes can be somewhat irritating, and that actually can make it worse. It's hard to explain that to the patients, that they just have to sort of wait and be gentle with it and let it happen. Now, the type of hairy tongue you do have to worry about is there is one type you have to worry about, and that is black hairy tongue. Okay, black hairy tongue is different than brown or blue or red. Those are all extrinsic stains. And even though this is an extrinsic stain, this usually happens when the patient has there's only 1 or 2 possible reasons that a patient's going to show up with black hairy tongue. And I'm going to just tell you a quick story about my dad, who was a dentist, who should have known better. And what happened was this: my dad called me up one morning around 6 o'clock in the morning. He's like, "Gwen, my tongue is black." I was like, "Okay, Dad, that's okay." I was like, "Did you take Pepto-Bismol in the middle of the night?" Because oftentimes patients who are having upset stomachs will take Pepto-Bismol in the middle of the night. The bismuth gets under the leaves on the filiform papilla and will actually turn them black. So that is actually a really common reason that we see this, especially with the liquid Pepto-Bismol when people are not rinsing their mouth out afterwards. Oftentimes, if they're using the tablets, they'll have a drink of water so it doesn't really get in there as well. If this is from Pepto-Bismol, what you'll do is between 2 or 3 days from now, it's going to go away on its own. You can have the patient very gently clean it. In this case, you can have them use a tongue scraper, but make sure they're not really scrubbing their tongue, because that's going to make it worse. Now, this is not what happened to my dad. My dad, although he was a dentist and should have known better at this point, had a sinus infection. So he put himself on a nice broad spectrum antibiotic for 10 days. It didn't get better. So he put himself on another broad spectrum antibiotic, and it didn't get better. So he had already had about 20 days of broad spectrum antibiotics in him, and then he went to see his ENT. He did not tell his ENT that he had already taken 2 series of broad spectrum antibiotics, and his ENT actually put him on Cipro. And about 3 days later, which is when he called me, he said, my tongue is black. And I'm like, okay, Pepto-Bismol, la, la, la. And he's like, no. I was like, okay, Dad, what have you been doing? And he's like, well, I've had about 2.5 weeks of high dose antibiotics. And I said, fine, meet me at the hospital. And I would like to say this was one of the 3 times that I saved his life, so I was very proud about that. He should have known better, but he didn't. One of the things that we now know about black hairy tongue, not brown, not blue, not red, but black. If you have a patient with true black hairy tongue, the only 2 reasons we're really going to see it is going to be Pepto-Bismol in the middle of the night. And the other one is that they have actually wiped out all of the flora that's in their gut, and that they need, and I've made this word up, but they need to be refluorinated. And the way that they are refluorinating people now is they're actually giving them frozen poo pills. Now, I don't know exactly what makes one person's poo better than someone else's poo. I'm sure if you talk to a nearby hospital near you, you can find out. But let me tell you, people with good poo, and I don't know again what the criteria are making about $50,000 or $60,000. And they just literally show up at the hospital with poo. And what they do is they will put the poo into gel tablets, which will then get frozen, because who wants to have a soggy or a non-frozen poo pill. And what happens is they will take the pills and they will actually wind up getting new flora that's coming back into their gut. And this is how we are now treating patients who have black hairy tongue caused by too much antibiotic, and it's usually due to C. difficile or Clostridium difficile. So that is the only type of hairy tongue that you really need to worry about. We're moving on to pyogenic granuloma. This was a young Hispanic woman who was one of my patients. She was not pregnant. When I went to dental school, I was basically told two things that were complete and total lies. I don't think that they meant them to be lies, but I think it's what they knew at the time. I was told that pyogenic granulomas occur on the gingiva only, and that I was also told that they occur in pregnant women only. First of all, let me just tell you, the first place that pyogenic granulomas actually show up on the body is actually the skin of the breast. It's and that is where we see it most often. But when we do see it in the mouth, it could be on anywhere in the mouth, because most likely and more often than not, it is a reactive lesion. And you can see here that it is growing so quickly. It's almost like a hemangioma, like a small capillary hemangioma that's growing so quickly that the epithelium is not being able to stay on and grow as fast as the connective tissue. So it tends to be very vascular and very fast growing. Now, the other thing is, when I went to dental school, I was told that this was called a pregnancy tumor. I stopped calling it a pregnancy tumor many years ago for a couple of reasons. The number one reason actually was that I had a 12-year-old girl who had a pyogenic granuloma, and it was due to her wearing braces. And telling a mother of a 12-year-old girl that the student I was working with actually accidentally called it a pregnancy tumor, it did not go well. We had to sort of calm the parent down a lot. The child was actually horrified. But I've also had some of my students, in their enthusiasm, have called this a pregnancy tumor in young men or boys who are going through puberty. This is not that different than a puberty gingivitis. Do we see it in pregnant women? Yes, we do see it in pregnant women. We see it in pregnant women all the time. This woman happened not to be pregnant, but this woman was. And the size of the lesion was about 2.5 centimeters on the lingual, and it actually extended as far on the buccal as well. So this was also in the anterior. You can see on the surface of the lesion itself that you can actually see imprints of the mandibular central incisors on here. So this was growing quickly and it was growing fast, and she was about 7 months pregnant. When we were talking to her, a lot of people were like, oh, we don't want to do any surgery on pregnant people. I was like, look, she has a 4.5 centimeter mass that is on the buccal and the palatal of her anterior maxilla. So every time she opens her mouth, everybody's going to see it. And plus it's bleeding all the time because it's so fragile that she was ripping it all the time. So, you know, I have zero issues with having a patient in the 3rd trimester have any surgery that they need to have. And about 17% of these pyogenic granulomas in pregnant women will go away on their own. They don't always go away on their own, but they certainly can. They can also be seen when you have a patient who has, this tooth has broken, and this is actually a pyogenic granuloma that is growing off of the gingiva and actually growing into the area where the tooth was. So you can have a pyogenic granuloma due to deposit, you can have it due to hormonal imbalances or increased amount of progesterone and estrogen, or you can have it due to something like this where you have a broken tooth. So I see them secondary to calculus, I see them secondary to a topical irritant, and the best way to take care of them is to just go down to the very base of where they are, remove them from the base, clean everything out, make sure there isn't any deposit or any broken tooth or anything else that's in there that's a topical irritant, and we're very easily able to take care of that. Okay, I'm going to briefly talk about pemphigus and pemphigoid. I had a hard time when I was in dental school sort of trying to figure out the difference between pemphigus and pemphigoid. I know that I was told, and many of you were told, that it actually occurs in white Ashkenazi Jewish women who are middle-aged. So I always tease my class. I'm like, yeah, just think of me because I fit all those criteria. But I'm also going to tell you that that may not be 100% your actual patient population, because almost all of the studies, the huge studies that were done on both pemphigus and pemphigoid, were done in Manhattan at Mount Sinai Hospital, which is a Jewish hospital, in the 60s. So especially during the 60s and the 70s, a lot of the hospitals were, they were Catholic hospitals, they were Jewish hospitals, and people tended to go to certain places. So they were seeing a lot of pemphigus and pemphigoid in white Ashkenazi middle-aged Jewish women, but it doesn't have to be. This is actually a Hispanic woman who came in, and she had been told by her periodontist, unfortunately, that if she had just kept her mouth a little bit cleaner, she wouldn't be having this problem. Honestly, her husband was ready to leave her because he didn't understand what was going on. And I would like to say that one of my students actually looked at this and said, Dr. Brown, I think this looks like pemphigus, because we had already had pathology in class. And I said, I think this looks like pemphigus or pemphigoid. And I thought she did a great differential diagnosis. And what you have in pemphigoid is this. Pemphigus and pemphigoid are both autoimmune diseases. In pemphigoid, the body is attacking the basement membrane cell zone antigen. It is desmoglein 3, and what happens is that the desmosomal attachments, where the epithelium attaches to each other, to the connective tissue below the epithelium, separates. So it really looks very, very bright red, and it really looks very, very uniform. It comes off almost in a sheet, so that this actually has what we call a positive Nikolsky sign. A positive Nikolsky sign is the ability to create a blister with gentle rubbing. And there are a few things that have a positive Nikolsky sign. We'll talk about them, a couple of them today as well. But pemphigoid is not as bad as pemphigus. Pemphigoid, the suffix oid means like, so it means it is like pemphigus, but it is not as bad as pemphigus. This is not a fatal disease. I will treat these patients. I will treat them topically. I will also work with the dermatologist. If you are in the New York area and you can get your patients over to Bellevue or NYU, they have an immunodermatopathology center there. Let me repeat that, immunodermatopathology, and they're even a smaller group of people than the oral pathology people, like where I am, and they work really well. I was working with them probably for about 20 years. Unfortunately, the person who I had been working with has passed away, but they still have a very strong immunodermatopathology department, and they will work with you to help you whether the patient has skin lesions or oral lesions. And anybody who has pemphigoid, not pemphigus, but pemphigoid, they need to have an eye lesion. They have to have an eye exam as well. What happens is sometimes they will develop eye lesions, and they're actually called symblepharon. And what they are adhesions between the inner aspect of the eyelid and the conjunctiva of the eye. And if you get these adhesions, if you get a lot of them, it doesn't allow your eyes to move right and left and up and down. And sometimes patients can go blind from these. So we do see anybody who has a patient who has been confirmed as having a diagnosis of mucous membrane pemphigoid, which used to be called benign mucous membrane pemphigoid. If you see a patient with pemphigoid, you're going to want to refer them out for an eye exam as soon as possible. This is the same patient, and I just want to point out here that you can begin to see where the blisters actually forming, and you can see here that the skin is still attached at the gingival margin. It's still attached, whereas over here it's already gone, and there's little bits of gingival attachment that are still there. This is incredibly painful. So for these patients, I will use a topical steroid. I usually will go with Lidex or fluocinolone, or sometimes I'll do Temavate or Ultravate. I tend to use a gel more than anything else because they're water-based. I don't use creams because they don't last as well and they don't taste very good, but the gel lasts about 10 minutes. I have them dry their mouth out as much as they can, just like breathing through their mouth or just like blowing air into their mouth. Get the area as dry as you can, and then I have them put on a very, very, very small layer, just like a pea-sized drop onto this whole area. Or if we go back to this slide before, I will have them use just a pea-sized area to cover all of the tissue. You need very, very little of it, especially if you're using one of the ultra-potent topical steroids. Now, some places will say, some pharmacies will say you're not allowed to use this in the mouth. We have enough literature, which I can certainly get to Dr. Joachim or anybody who needs it, where I have the literature saying that the standard of care by the AAOMS, which is the American Academy of Oral Medicine people, so that they will actually basically say that fluocinolone or Lidex is their first choice. So if we're looking at steroids and we're looking at comparative levels of steroids, Kenalog and Orbase, you would need to apply 10 to 12 times a day. Lidex, you can apply between 3 and 5 times a day. And if you're going with one of the ultra-potent topical steroids, which I don't usually do because they can be a little bit irritating to the patients unless it's very, very bad, those only need to be applied once or twice a day. I also will make sure that this patient will have a nystatin suspension, and I will do that to prevent them from getting a yeast infection, because I have given enough very nice, lovely people accidental yeast infections in my life. So now I just assume the patient's somewhat xerostomach, they're on medications, they're a little bit older, and I will give them preventive nystatin suspension. And I usually just have them do that twice a day. So the regimen is this. If you're using Lidex, you have the patient put it on after breakfast, keep it on for about 5 minutes, wash it off, rinse it off with some water, and then have them put the nystatin suspension on a gauze pad, have them sit it in their mouth, make sure they take their dentures out, have them sit it in their mouth for about 5 minutes, and it will get better very, very quickly. And these patients know when they need to use it. I can't cure this. This is an autoimmune disease. I can't get rid of it. All I can do is treat the patient when they're in pain. So because this is not a fatal disease, and this is something I can treat, I work with the dermatologist, and it's very easy for these patients to know when they're having actual issues. Now, pemphigus vulgaris is different because pemphigus is a fatal disease. And before the advent of corticosteroids, immunosuppressants, and antibiotics, these patients would die like burn victims died. What happens is that, I'm going to go to the next page because it just shows a little better, that the tissue actually falls apart. It is autoimmune. It is attacking the intercellular cement that keeps the epithelium together. So this is a mucocutaneous disease, as is pemphigoid, and it is an autoimmune mucocutaneous disease. Again, originally thought to be seen predominantly in Ashkenazi Jewish women over the age of 50, over the age of 40. But I have seen this. I had one 18-year-old young Hispanic man who was actually kicked out of his household because he developed pemphigus, and his parents thought that he had AIDS, and they didn't want him giving it to the rest of the family. So biopsying something that you don't know what it is always a good idea. When you are doing a biopsy, you want to do a biopsy of not just the erosive area, because if you do this, all you're going to get is a picture of an ulcer. So you really want to do a biopsy showing some ulceration, but you also want to have some of the epithelium as well. And this is really hard to biopsy. And so sometimes they're going to do blood tests for it. And they're also going to do they're going to do biopsies with special stains that will show a very specific, sort of a chicken wire appearance to it. So microscopically, we can make the diagnosis. We do like to have confirmation with immunohistochemical stains, as well as with blood stains, and with blood draws as well. And again, for patients with pemphigus vulgaris, this is something that they could die from. And they die the way burn victims die. They die from fluid loss, electrolyte imbalance, and kidney failure. For this patient, you can see that she's had some very, very poor restorations done on the, especially on the gingival margin, because she was also incredibly xerostomach. She was really having a hard time brushing her teeth as well. So one of the things that we did was we actually had her come into clinic every other month, and use a very, 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 very low power thin cert, and then you do a lot of hand scaling for these patients. I always make sure that I work with the doctors. I do not ever prescribe anything for my pemphigus patients that I haven't spoken to their primary care physician about, because it is potentially fatal, and I don't want to give them too much of one thing or another. For these patients, sometimes I will give them a little bit more of an ultra-potent topical steroid. And the thing you have to remember is that they have a really hard time brushing their teeth, that every time, if they're going in here and they're using like a modified Bass technique, that they can literally rip off the tissue, and it becomes quite uncomfortable for the patients. Go to the next slide. This is also the same patient, and you can see this is her tongue. You can see all of these are blisters. These are not like fissure tongue. These are actually blisters that have ruptured, and this entire area was a blister that came off. So she was in quite a lot of pain when we saw her. And so sometimes with these patients, we'll treat them for a couple of weeks with the topical steroids, talking to their primary care physicians, who sometimes will put them on prednisone, and then we'll have them come back and we will take care of them. And it is really important for these patients to have as good oral hygiene as they possibly can, because the patients will wind up losing bone loss. They can't brush their teeth and they're really uncomfortable. So we really want to make sure they're okay. This woman, I've been seeing her probably for about 15 years. I haven't seen her since the pandemic, and I'm hoping she's doing okay. She was absolutely fantastic. She let all of our students come in. She's like, oh yeah, bring everybody in there. They've never seen this and they need to know what it looks like. So we have really good patients at the clinic. This is not my slide. I apologize for that. It was given to me, but this is a case of erythema multiformi. Erythem multiformi is one of the 4 conditions that you really need to know about that can cause a positive Nikolsky sign, again, which is the ability to create a blister. A typical or the traditional positive Nikolsky sign was you were creating a blister by gently rubbing either skin or mucosa with a pencil eraser, which we are clearly not allowed to do anymore. But you can get the same kind of traction using a nitrile glove, or if you're still using latex, you can certainly get it with latex. Erythem multiformi is a type 4 hypersensitivity type allergic reaction. So that what happens is the patient will actually wake up in the morning, and this was about 12 hours after the patient had first been seen at the hospital. But let me tell you a little bit about this patient, because I do know about this patient. So this patient was a sex worker. They were an HIV positive patient, and they also had a heroin condition where they were using heroin every day. And what had happened was every, I don't know, 4 to 6 months, her regular heroin dealer would be not there. So she'd go to a different corner and get heroin, and she'd wind up in the hospital. So I got a phone call from the emergency room for a patient basically looking exactly like this, saying, we have a patient, this is their 4th time that they've had erythem, it's the 4th time that they've had primary herpetic gingiva stomatitis. And I said, that's not possible. And they're like, well, they're HIV positive. As I think, well, it's still not possible, because once you've been exposed to HSV1, it usually lives in your trigeminal root ganglion for your entire life. If it's HSV2 and it's genital, it's your dorsal root ganglion. And if it's varicella zoster, it's actually in your spinal cord. So if it was her first exposure to this, yes, she would have primary herpetic gingiva stomatitis, but you can only get primary herpes once. You can only get it once. And they said, and the very nice, incredibly young resident looked at me and said, but this is the 4th time I've seen her, and we put her in the hospital and we gave her IV fluids and acyclovir and sort of detoxed her off of the heroin. She didn't have to do sex work. She had a bed for a couple of weeks until she got better. And I said, did it ever occur to you that this might just be a self-limiting disease on its own? And what happens with erythema multiformi, and we don't know exactly why it happens. When I was in dental school, I was told that it happens half of the time, at least half of the time it was a drug reaction. Now we know that at least half of the time we have absolutely no idea why it happens. In her case, it was probably not due to the heroin, because she didn't have it when she went to the heroin place that she liked, but it was probably due to whatever the person who was selling her heroin was mixing with on the other side. And what happened was she developed this really weird allergic type of a reaction that was causes bloody, crusty lips. You've probably have heard that term before. And then they get a very symmetric ulceration on the gingiva, on the inside of the mouth, on the tongue, on the movable mucosa, on the non-movable mucosa, which is probably why they thought originally it was a primary herpes. But I said, look, if you put a person who's HIV positive, who's not taking their meds, and you give them their meds, and you give them a warm bed to sleep in, and you give them 3 meals a day, and you give them IV fluids and acyclovir, why not? But they're going to get better on their own. So this is erythema multiforme minor. You can also have erythema multiforme major. Erythema multiforme major, you may have heard as Stevens-Johnson syndrome, but it's exactly the same thing, only it's also going to involve usually the eyes, the nose, and the genitals, okay? So as soon as you start seeing a patient who's having this, and again, this is developing basically overnight. This person went to bed, they were fine, they woke up the next morning and they had lesions everywhere. Now, I've been lucky enough to get erythema multiforme, and I have no idea why I get it either. I don't get it quite this bad. I wind up just looking like I've had a very bad Botox experience. But for patients who we do know why it happens, and that's about maybe half of the patients. Some of them it's a drug reaction. I had one nurse who did something I certainly could not have told her to do. She went on medication. She went on birth control pills. She got off the birth control pills, and she tested herself the next month by going on birth control pills again and wound up in the hospital again. For the most part, though, it is either an upper respiratory viral infection or an intraoral viral infection. And I don't know if any of you remember the commercials that were seen on TV a few years ago. They were for Valtrex, and they said something like 80% of people can still give herpes to their partner, even if they don't know that they have it. And this is true. It's called asymptomatic viral shedding. 80% is really high. It's actually about 20% of patients with genital herpes will have asymptomatic viral shedding, but 5% of people in the world who don't even know that they have herpes will have asymptomatic viral shedding in their mouth. So they may always have virus in their mouth. So one of the things we actually will do is we'll treat this patient with steroids, we'll get them comfortable, we'll make sure that they're okay. Sometimes topical steroids, sometimes systemic steroids, depends on how bad it is. This patient looks like they could use both topical and systemic steroids, but we're also going to put them, especially patients who have chronic erythema multiforme minor, which we do see occasionally. Those patients we're actually going to treat by using an antiviral preparation. So I'm actually going to give them either acyclovir or valcyclovir. And if I can prevent them from getting a viral infection, they will not then develop this hypersensitivity type 4 allergic reaction to the virus that's always in their mouth. So I assume that if people who get chronic erythema multiforme will always have this viral infection in their mouth. Can it happen in kids as well? Yes. So this young lady was actually thought to have been chewing on a wire, like a electrical cord, but she didn't have any lesions inside her mouth, and we kind of got to her beforehand. She's a person of color. So again, you're going to see something a little bit different in patients of color. So it's going to be a little bit darker, and this is basically the bloody crusty lips in an earlier stage. It has not formed into a scab yet. For patients who are kids, I tend to put them in the hospital, or I talk to their primary care physician, because they really do need to stay hydrated. This is a good time when you can give them all the ice cream that they want to eat. And the positive thing about erythema multiforme minor is that even if you don't do anything, these patients will get better on their own within 2 or 3 weeks. They're just going to have a pretty rough 2 or 3 weeks. So we do like to treat them whenever possible. I'm going to switch into oral lichen planus. This is your basic Wickham striation. There are basically 4 types of oral lichen planus. You have Wickham striae, you've got erosive lichen planus, you've got a bullous lichen planus, you've got a plaque lichen planus. And one of the things that happened when I went to dental school, we had Schaefer, Hein, and Levy. I memorized the book. The book basically said, lichen planus can be red, it can be white, it can be bullous, it can be erosive. I was just sitting there going, how can one lesion have all these different clinical presentations? But what happens is this, on a microscopic level, the basal cell layer starts to liquefy. So it sort of becomes a liquefactive degeneration of the basal cell layer, and it separates a little bit from the connective tissue underneath. But if you are liquefying your basal cell layer, and your basal cell layer, the only thing you want your basal cell layer to do is it is stratified squamous epithelium. So you're basically looking to see keratin being formed. So if your basal cell layer is melting or becoming really fluid, the number and the amount of keratin that's going to be formed is not going to be normal. So the plaque-like areas, which are the thicker areas, have extra keratin. The Wickham striations have extra keratin. And if you look in the areas where you have this erosion type areas, where you're basically looking into the connective tissue, those areas are going to be incredibly painful. So the hyperkeratotic areas, the patients just mostly will tell you that their cheeks are a little bit rough, they're uncomfortable. But the patients with erosions have two things that you need to know about. One is they do need to be treated. It is an autoimmune disease. We don't know exactly how it works, but if you put a gun to my head and say, what is this? I'm going to tell you it's autoimmune. It hasn't 100% been confirmed. It is mucocutaneous. A lot of women will also get it vaginally. For people who get it on the skin, they get it on the areas where their arms and arms and legs will close, so that there will be contact between the forearms and their skin, or the back of their legs and their calves. So that's where we typically see it, and it's very, very itchy for these patients, so they do sometimes know they have it. For women, we actually often see it, and they will have vaginal oral lichen planus, which has unfortunately usually been misdiagnosed or mistreated as a yeast infection. So as soon as we get a positive diagnosis or a positive biopsy, and again, when you're biopsying, do not biopsy just the ulcer, because all you'll get is a diagnosis of an ulcer. So you want to biopsy not just the Wickham striae, you want to biopsy something that's a little bit white, and you can also biopsy some striated areas. But the other issue that you have to worry about is the fact that there is an increased likelihood of the patient developing a malignancy in oral lichen planus. It's not a lot, it's about 1.5%. But I do follow these patients. So for patients who have oral lichen planus, I will have the patient have photos taken. I take them usually 2 or 3 times a year. The only type of photo that is really legal, sort of, because you cannot change it at all, is actually a Polaroid, which is no longer made by Kodak, but Fujifilm makes them, and you can buy like a 15-sheet Polaroid. So even if your office has gone into pure paper, getting away from paper and is purely digital, what we do is we still have the patient sign the back of it. I sign the back of it, we date it, we say we've had the conversation about oral lichen planus and that there is a possibility that the patients will develop a malignancy. This is a very typical, very small lesion of lichen planus. I am expecting to get this at any point in my life sometime soon, only because my mom has it, my grandmother had it, and my aunt have it. So, I think it's something that I will somehow or other develop as well, but I do know how to treat it, and I do know what I'm looking for. This is a beautiful erosive area with striation, Wickham striations around it. And this is what we typically see, but it can be much worse. So this was a patient who was my patient for about 10 years. And for about 9.5 years, she looked like this. We did multiple biopsies. I'd like to do biopsies on patients with lichen planus every 3 to 5 years, just to confirm that nothing has changed. And she came in to see me about 4 months after she had been with here. She had looked like this for about 9 years. She was a dental hygienist, so she actually had some idea of what was going on in her mouth. And you can see here that it's beginning to just fall apart. So we had her have multiple biopsies. And when you have something that's 3 centimeters in size, you want to do multiple biopsies in different bottles. So you can have an A bottle, a B bottle, a C bottle, and you want to make sure you're looking at all different areas, because there is an increased risk of patients developing and malignancy with these patients. And I want to show you one of the patients I have that did have a malignancy that developed. And this was a patient who had a malignancy under a denture. And I really cannot impress upon you enough that these patients, first of all, every time they put their dentures in and out, sometimes they're ripping off the tissue. But the problem with not taking the dentures out, especially not taking the dentures out at night, it doesn't give the tissue a chance to heal. Again, what I would do is I would have the pharmacist compound a little bit of a topical steroid, usually a 1-to-2 ratio of topical steroid with topical nystatin, and have that. And then I have the patient use it as a stent under the denture. And then what I do is I'll look at the patient again after a couple of weeks, and I'll see if there's any still red and white areas that should be biopsied. And this patient actually did go on to develop oral squamous cell carcinoma. So there is an increased risk. We do know that it exists, and we'd like to make sure that you are aware of it. When you're seeing it on the dorsal surface of the tongue, it looks a little bit different. And if I had a patient who only had this on the tongue, lichen planus would not necessarily be my first thought. I'd be a little bit concerned about this area over here being a little bit of a mixed red and white lesion. And again, red and white lesions need to be biopsied. And sometimes they look a little bit like cobblestones. So this is a patient who has lichen planus in other parts of her mouth, so I wasn't really concerned. But if you're doing biopsies, you do want to have a confirmation biopsy as well. How am I doing on time?
We have 5 minutes to go, Dr.
Okay, do you want me to stop here and take any questions if there are any questions?
Yeah, maybe we could do that. And just a reminder to the attendees, you have to be logged on for 50 minutes to earn the CE credit. If you need to drop out after 50 minutes, feel free to do so. There's a couple of questions in the chat, Dr. Cohen-Brown. The first one is, what can you say about ameloblastoma?
And it's from my friend Helene. Hi, Helene.
Yes.
Okay, what can I say about ameloblastoma? Well, this lecture is really more of a soft tissue lecture rather than going into bones, which I can certainly do on another lecture. When we see ameloblastoma, again, there's two basic types of ameloblastoma. There is ameloblastoma that we see in the older population, and by older, I'm sorry to say, I mean over the age of 40. And what we have is usually it is a multilocular, multicystic lesion that tends to grow very quickly. Patients sometimes don't know what's happening until they're getting a movement of their teeth. The other type of ameloblastoma is a unicystic ameloblastoma, which we see usually around the third molars. That's the most likely place that we're going to see it, around the second and third molars. I always tell my students that if you're looking at a multilocular radiolucent lesion in the posterior mandible, third molar ramus area, there's really only 5 things that it's going to be. You're going to have ameloblastoma, you're going to have myxoma, you're going to have central giant cell granuloma. You can have a hemangioma. That's usually sort of like the red herring, and I'm completely spacing out on the other one because I wasn't planning on talking about ameloblastoma. Give me a minute, I'll think of the other one. And basically, so you have this multilocular radiolucency, central giant cell granuloma. So if we have this multilocular radiolucency, you definitely want to take biopsy, but you're also, when you're treating it, when it's multilocular, it's definitely, in more times out of not, at least 2/3 of the time, it's going to be from the distal of the or in going up into the ramus, and it'll usually go into around the first or second premolar. And I usually, the patients have to understand that if it's in the mandible, they need to have usually about a centimeter round around it, and you have to remove the soft tissue as well. It is a major surgical procedure. If it's in the maxilla, you actually have to have 1.5 centimeters going around it, because if you are dealing with the maxilla, the likelihood exists that you're going to be having the tumor can go into the sinus area, and that can spread. And I've actually had one patient, although it's only one patient, I have one patient who wound up getting a brain tumor from direct contact of the ameloblastoma that went up directly into the patient's brain. So the 2 types of ameloblastomas, one is basically almost like a dentigerous cyst, a little more aggressive. You have to remove the whole thing. It is called a unicystic ameloblastoma. But the ones that people are really most worried about are the multicystic or multilocular ameloblastomas. The way I explain what it looks like is that if you think of what a thing of grapes looks like, just like a little bunch of grapes, and you stick that into the middle of the patient's jawbone, and then you take an x-ray of it, all those little locules start hooking up together, and they are going to basically connect to each other because this is an aggressive tumor. And they used to think it was really a malignant tumor, but they have more or less decided that it's not so likely to be malignant as it is that it can spread. Not so much, so sometimes during the surgical procedures, it can go into the lungs, which is the most common place to see it. Okay.
Thank you so much. Hopefully we'll have you back for some more courses in the future. We could cover more lesions. There's one more question before we wrap up, and I think that's a great question. What is
it is a great question. Well, I'm going to be a little prejudiced.
Pathology text. Yes.
I'm a little prejudiced because I just wrote one, but I'm also going to tell you the truth that for my dental students, or if I'm teaching upper level, I actually do like oh boy, what is it? It was the Shuba book, but I'm not as crazy about that as I was because it's a little bit over. It's a little bit over. I like the Doug Dam, and I think it's the Doug Dam book. I'll get you the name of the book, and I'll get you the name of my path book. So my path textbook was written for clinical people. It was not written for people who are in school. A lot of the pathology textbooks that they have don't have as many photos in them as I would like to have. And so it's I think it's Doug Dam, Jerry Boku. It's a really good book, but it is really written for people who are preparing to take their boards. So if you don't need a book talking as much about the biopsy and you want something more on clinical, you know, we can hook you up with my book. If you want something that really goes into what it looks like microscopically, I would definitely recommend the Doug Dam and Jerry Boku book. And I'll get you the name of that. I can send that to Dr. Joachim afterwards.
Great. Well, thank you so much, Dr. Cohen-Brown. It's a pleasure having you as part of our series. And like I said, hopefully we'll be able to have you back again. Before we wrap up, I just wanted to remind everybody we will have one more course. Well, actually a number of courses coming up, but I'm going to let Lauren share her slide. I think the next course is coming up in a few weeks, I believe, is on occlusion. I think Dr. Brown, you might have to stop sharing.
Let me stop sharing right now. Hold on. Okay, am I off?
We're good. Oh,
Okay,
there it is. So the next course is on June 8th, and it's on principles of occlusion with Dr. Zhu. So please feel free to join us for that course as well. And hope everybody has a great evening. And thank you again.
Thank you so much for your time. And it was a pleasure being here. And thank you so much for the invitation. I really appreciate it.
Thank you.
Are we live?
Yes, we are, but we still
Thank you
have
so much.
You're welcome.
I appreciate the beautiful, actually, Sam is calling me right now.
Okay. Have a good evening.
Thank you, you too. Hi. I am